So I'm going to talk on a very ancient topic, an update on a very ancient topic. So myopia, we know that it's going to be a significant visual health problem. And high myopia and pathological myopia compose around 3% of the total population, and this is going to increase. A lot of these patients are having bilateral disease, and since it affects the younger population as compared to neovascular AMD, it is going to cause social and economic impact. The myopic CNV in fellow eye risk is much higher if myopic CNVM development risk is much higher if the fellow eye is already involved. If there are crisscross lacquer cracks, if the choroid is thin, especially under the fovea and inferior macula, and there are other factors which increase the risk factors for myopic CNVM. This is one of the recent papers talking about parapapillary atrophy and the ratio of beta zone to the disc area, and saying that this is probably a significant factor for increasing myopic maculopathy and myopic neovascularization. So we know about the mechanical stress and the hemodynamic theories, which starts with progressive axial elongation and ends with neovascularization. The diagnosis of myopic CNVM is sometimes the patient himself or herself tells the symptoms and it is diagnostic. And when you see a small flat grayish subfoveal or juxtafoveal subretinal lesion, and on OCT you will see a type 2 MNV with variable amount of SRF, but the most important factor is the haziness or blurriness of the ELM. On FFA, you will see a classic CNVM. Leakage is proportional to the size and activity of the lesion and RP health, and leakage sometimes can be very subtle. ICG helps in diagnosing or identifying lacquer cracks and choroidal atrophy, and OCTA has been shown to be having very high sensitivity and specificity to detect myopic CNVM. And there are two types which have been described, which I'll come to later. So this is a simple multimodal imaging, helps to identify myopic CNVM, hyperfluorescence on FFA, and OCT you'll see this region where there is ELM disruption or fuzziness, and this disappears with treatment. This is the OCT angiogram after treatment, leaves a residual skeleton of the CNV. So this is the paper by Kirk's group. They showed disorganized vascular loops and highly organized interlacing network. The second has a halo and a core, which helps to say that this is a more active disease as compared to the former, the disorganized vascular loops. They've also described in the same year another paper where they talk about irregular, well-defined tangled CNV, which they say is suggestive of an inactive disease or regressing disease. So we've seen that through the classifications of META-PM and the ATN classification, that neovascular component is now identified as a separate entity, and it can be associated with atrophy and traction. So what are the predictors of poor outcome? Older age, as we understand, because of the choroidal atrophy, subfoveal location, larger lesion size, poor baseline visual acuity, and the duration of CNV being the significant factors. But why leave the good? If there is subfoveal choroidal thickness is greater, and if there is intact ellipsoid zone at baseline, it indicates better outcome. There are diseases, there are factors which influence the recurrence. Again, older age, larger lesion size, juxtafoveal location, and this all will be associated with higher and increasing recurrence and need for repeated treatment. The recent paper talks about perforating scleral vessels, which come to the center of this CNV. They originate from the short periphery, and the patients who have posterior perforating scleral vessels are known to have more recurrent disease. There are certain protective factors extrapolating from other diseases, cilioretinal artery and dome-shaped macula being the most salient ones. The differential is sometimes difficult. A coin lesion which does not show any leakage on OCT, on FFA, can look very similar to CNVM on OCT. So FFA is supposed to be more diagnostic and has higher sensitivity on picking up myopic CNVMs. Lacquer crack, which is fresh, can sometimes be hyperfluorescent on FFA. Again, just observing these cases can help achieve normal resolution of the disease. Dome-shaped maculopathy we have already understood and tilted disc macular. And this is a case which I saw recently showing polypodal-like lesions at the staphyloма edge. It could as well be staphyloma associated or induced serous maculopathy. Punctate choroidopathy again can have multifocal lesions. If you have multiple hyperfluorescent lesions on FFA, it is you should suspect PIC rather than CN, multifocal CN.
So I think we can.
Yeah, just this last slide. So lesion characteristics: active, scar, and atrophic. Small grayish subretinal lesion without subretinal hemorrhage, and early hyperfluorescence which becomes staining into the scar stage and later on causes atrophy. So there are papers now on AI associated understanding of the disease, and all these factors mentioned here indicate that we may be able to predict myopic maculopathy and forecast development of myopic CNVM in certain cases. Thank you for your patient listening.